Here we have a case with failing blade implants and mini transitional implants. These implants were supporting a denture that was utilized as a fixed prosthesis. The prosthesis was mobile and the patient was suffering from paresthesia. Here you find the prosthesis being sectioned to enable the failing implants to be removed. It is not advisable to remove a failing prosthesis supported by mobile implants in toto. The mobile implants are attached to the connective tissue and the surrounding mucosa. Hence, care must be exercised while removing these mobile implants, as you would tend to lose more attachment. Here you can see the intaglio surface of the failed prosthesis. When the prosthesis is tried to pry away from the failing implants, and if it does not move, try to section the prosthesis further so that the failing implants do not cause further trauma. The mini implants should be unscrewed carefully rather than pulled, so that the mini implants, which are adhering because of the tenacious connective tissue fibers surrounding the walls of the implant, it would cause tissue trauma by damaging more of the attachment. Here, the failing blade implant is carefully removed. A mid-crestal incision alongside the shoulders of the implant is carried out to the depth of the connective tissue attachment. The advent of piezo has made this process much more atraumatic and very precise. Previously, we used to use a 700 XXL burr alongside the surface of the implant and then carefully pry the implant out. Here we can conserve the lateral surfaces of the bone alongside the failing implant and consider bone grafting procedures if future implants are planned. The implant is then carefully removed, and scalpel is sometimes used to further sever any connective tissue attachment that may be holding the implant. The contralateral side is also treated in the same manner. You can see that though the implants are mobile, the mucosa covering the shoulder of the implant is still intact, and sometimes you may even find some bony projections that may tend to cover the shoulder of the implant. Here, the mid-crestal incision is being placed on either side of the head of the implant. Again, care must be exercised to ensure that the incision does not go over the mental foramen. The piezo tip is again used to separate the implant from any bony adherences and connective tissue fibers that may hold the implant in position. In such areas, it may sometimes be wise to curette the sockets and let the socket osteotomies heal by themselves without any graft material. If future implants are planned, a full thickness mucoperiosteal flap should be elevated, thorough debridement should be carried out, and after ensuring all of the connective tissue has been removed, then grafting may be considered. In this particular case, the patient opted only for dentures.